Hey, so hi everybody, welcome to our third Radiopharm Theranostics webinar. I am Dimitris Voliotis. I am the Radiopharm Chief Medical Officer, and I can see that we still have people joining, so let's give it another like 20 seconds or so until the counter stops. I think we're good now. So again, welcome everybody. I'm Dimitris Voliotis. I'm the Chief Medical Officer of Radiopharm. Good morning to the folks joining in Australia. Good evening to everybody on the East Coast. And if somebody is joining in from Europe, it's in the middle of the night, so I hope you're having a good night. So welcome, as I said, to our third webinar. We want to discuss here the unmet medical need for patients with suspected brain metastases from solid tumors. Our first webinar, which was about 4 weeks back, was around prostate cancer and our new agent, B7H3 targeting agent, which we call BetaBart, that will go into the clinic in the clinical studies very soon this year, which also is treating prostate cancer patients. The second webinar, which was a week later, was around KLK3, which is another agent, very specific this time for prostate cancer, a very, very interesting, very specific target, as I said, in prostate cancer. And now I'm just very thrilled to have the opportunity to share some data and some thoughts around our first of all the unmet need for those patients, and also our thoughts about our own development compound, which we believe has the potential to hopefully sometime in the future address some of those needs. I am super excited to be able to welcome Dr. Ramji Rajendran as our key opinion leader here. Dr. Rajendran is a highly skilled radiation oncologist with a pretty unique background in both clinical practice and research. He completed his MD and PhD in a combined program at the University of Illinois at Urbana-Champaign. And his doctoral research focused on molecular mechanisms and cell biology of hormone-dependent tumors such as breast and prostate. After that, he completed his residency at the Hospital of the University of Pennsylvania in Philadelphia, and he has dedicated really his career to advancing the treatment through radiation therapy primarily, and he currently serves as the director of the Department of Radiation Oncology and the Illinois Gamma Knife Center at the Ascension Election Brothers Medical Center. His expertise spans a really wide range of advanced therapeutic techniques, including SBRT and Gamma Knife, and his research contributed to publications in prostate, proton radiation therapy, and radiation therapy for breast and thoracic tumor. So very thrilled to have you here, Dr. Rajendran. I will open the slides.
It is a pleasure to be here, and good morning, Australia. It's a pleasure to be here with you. Today, I would like to talk about challenges and unmet needs for radiographic detection of relapsed brain metastases from solid tumors and consequences for therapeutic approaches. So again,
Sorry, Ramji, just one second. I'm sorry to interrupt you.
Of course.
If the people on the webinar have questions, please do submit those questions in writing through our chat function. We cannot take questions verbally, so we have a chat function where you can submit all of your questions, and we will address them at the end. Apologies, Ramji. Go ahead.
No, not at all. It's a pleasure. So again, I'm Ramji Rajendran. I'm a radiation oncologist in community practice at Alexian Brothers Medical Center in the Chicagoland area. We have a unique opportunity that we've had a Gamma Knife program for over 20 years. And I haven't made it to Australia, but as close as I've gotten is to Guam. So I'd like to share some sunsets from Guam in the South Pacific. Next slide. So it's important to know that brain metastases are a huge portion of cancer care today. They're 5 times more common than primary brain tumors. Next slide. So as cancer treatments improve, patients are living longer and brain metastases are increasing in number. A large part of this is due to the fact that patient survival is greater, and advances in systemic treatment have extended the life expectancy for many cancer patients, giving the disease time to spread to the brain. The brain is a sanctuary site where it's difficult for chemotherapy and other systemic treatments to go. And we're now better to diagnose those tumors even as small as 2 millimeters, especially with MRI and gadolinium contrast. And they can detect brain metastases that were previously too small and asymptomatic to be found. And overall, there's an increased cancer incidence. And so the overall increase in cancer incidence contributes to a greater number of patients who have brain metastases. Next slide. So almost all cancers can spread to the brain, but lung, breast, colon, kidney, and melanoma are the most common ones that spread to the brain. Next slide. So I think that we really need to rethink how brain metastases are thought of. It used to be a terminal disease, and this was the end, and whole brain radiation was sometimes offered or just hospice care. But I think we need to rethink this because really metastases grow from in situ cancer and then cause an invasion of the lymphatic system and eventually the bloodstream. And there's arrest and extravasation into the watershed areas of the brain, causing tumors to form. But these tumors really do not invade the brain tissue itself, and they're still able to be treated in a way in which just the tumor can be treated and normal brain can be minimized with radiation dose. Next slide. So the way that we do this is called stereotactic radiosurgery, or SRS. It's a great way to treat brain metastases. It uses a highly precise, high dose of radiation to target and destroy tumors. I don't know if any of you have ever tried playing with a magnifying glass in bright sunlight, where if you focus the beam of radiation, in this case light radiation, onto a piece of paper, you can have a very dramatic effect. In fact, you can burn a hole in the paper. However, just next to that, there's no effect at all, and the paper is left undamaged. Next slide. So our baby, what we use to really do this, is called the Lexel Gamma Knife, which is a tool and sort of the gold standard for radiosurgery for brain metastases. It's used to treat malignant and benign tumors, vascular malformations, and functional disorders. It's about 7 o'clock in the evening here, but this morning I was treating patients, and the treatment times ranged, in fact, for today, between 40 minutes to up to 3 hours for a patient with multiple brain metastases. The patient communicates via a microphone and camera. Patient planning software allows for conformal shape of radiation treatment. I kind of describe it as each metastasis is sort of like a little bag, and then we fill that bag of marbles of radiation or shots of radiation that allow to just treat the tumor and still leave the normal brain untouched. It's a fully automated system, and it uses 192 beams of radiation, each of which can be in 8 sectors that have different sizes. And the accuracy of this, because it can have a frame, is less than a millimeter, 0.5 millimeters. And the stereotactic frame allows for maximum precision, even to treat the 5th cranial nerve, for example, for trigeminal neuralgia. So while everyone else sees this, next slide, we see this. So a really amazing machine. that can really deliver very precise doses of radiation to make sure that we are able to treat tumors with complete confidence and with the ability to tell the patient we have greater than a 90% chance that this tumor will be gone. Next slide. So here's a couple of examples. This is a 60-year-old patient with non-small cell lung cancer, treated to a single metastasis, here shown on the left at initial treatment, both in the axial and coronal sections. And on the right, you see 6 months later, that tumor is just a piece of scar tissue left in the brain, and eventually that gets smaller and smaller over time. Next slide. And here's another example of a 52-year-old woman with a melanoma that started with a very large metastasis, but this dramatically shrank just 5 months after treatment. And again, these are the pre-treatment or day of treatment on the left in axial and coronal, and on the right, 5 months later, you're left with a little scar. Next slide. So, it's really treatment of brain metastases involves a neurosurgeon, a medical oncologist, and a radiation oncologist. And it is absolutely a team sport, and it is multidisciplinary care at its finest. Next slide. So sometimes we see patients like this that has a large single brain metastasis in the frontal lobe, causing midline shift, causing a significant amount of edema. A patient like this would not receive Gamma Knife up front. They would typically receive a resection of this metastasis and then Gamma Knife radiosurgery to the tumor bed to prevent local recurrence. Next slide. However, a patient like this with 1 to 3 small to intermediate sized brain metastases can be treated with Gamma Knife radiosurgery alone, and there's a greater than 90% chance that those tumors will never recur. Next slide. However, when you have multiple tumors like this, one may require whole brain radiation therapy or discussions with the medical oncologist to see if systemic treatments would be appropriate. Next slide. However, when you have a patient after treatment with Gamma Knife, this is a patient, again, with the axial and coronal slices. On the leftmost is the initial treatment day, where a tumor was clearly circumscribed with a radiation dose and treated. 3 months later, there was a dramatic effect. I've shown you that there's just a scar tissue left. However, at 6 months, there's an increase in size. Not quite as big as the original treatment day, but by 9 months, there's a significant increase in size. There's also central necrosis in the middle, where the gadolinium contrast for the MRI cannot go. And so we're left to wonder, is this true recurrence? Did Gamma Knife fail? Or did Gamma Knife work so well that it recruits inflammatory signals, causing swelling of the tumor and swelling of the normal brain in addition? And do we place the patient on steroids after, or do we have the patient be considered for resection by a neurosurgeon? So this is where we're left to wonder what next steps should be. And the best we really can offer the patient is to do another MRI maybe in 6 weeks. And if the patient is symptomatic, we have to empirically put them on steroids and see what happens with time. But in the meanwhile, the patient also may be on immunotherapy where the steroids are contraindicated. The patient may also have symptoms that need to be managed and controlled. And so we're often at this point stuck. And an imaging agent that would be able to discern whether this is radiation necrosis or whether it's tumor progression would dramatically improve clinical care and allow us to appropriately select those patients for the appropriate next steps. Next slide. That may be the last slide. So, can a PET radiodiagnostic distinguish radiation necrosis from progression? in patients with suspected recurrent brain metastases, status post-radiosurgery. Now, this is the question. It's a common clinical predicament, and it's one where the whole multidisciplinary team is left to wonder, and most importantly, the patient is left without a clear answer. Thank you.
Thank you so much. That's such a great presentation. Just one question, maybe while I pull up the slides that we have on Rad 101. So this was a great example, I believe, the patient that you showed earlier, or the last patient that you showed there. So how would you, if you knew that you would have a metastasis there, how would you treat such a patient?
So this was a patient from last Tuesday, and we saw this patient, and we elected to place her on steroids. So she was given 4 milligrams of dexamethasone twice a day. Fortunately, she was not on immunotherapy, and she was able to tolerate the treatment. And we have to image her brain again in 6 weeks. And if she was symptomatic, if this was a melanoma and the patient was on immunotherapy alone, it really leaves us to wonder if we're doing the right thing, and we would be very much stuck. We're hoping that an imaging agent, such as a PET agent, will allow us to better discern whether this is one or the other, and allow us to immediately have a better, more appropriate clinical answer for these patients, and not just have them wait.
Thank you. Yeah, I believe it's also very important for people, whether it's the audience here or patients and doctors who are not treating brain metastases patients every year to, as you said also in the beginning, to realize that there are treatment options, right, for these patients, because up until very recently, it is what you said that many times those patients were left to hospice care, and especially if there was a reduced a patient with less who's less well as a general condition, and people were afraid to give them some sort of radiation or systemic therapy. They were just left without any treatment. And I think it's important to realize that there are, in fact, treatments for such patients as long as you can identify these lesions early enough, right?
I agree. Historically, there were patients that had a single metastasis that was completely resected and then received whole brain radiation. And we were still left to express to the patient that at that time, given the systemic treatments available, those patients that were, ideal patients today, no evidence of disease, on average lived about 11 months.
All right, good. Thank you so much. So I'm taking over here for a short outline of what we, Radiopharm, are trying to do to maybe help patients and treating physicians to really get to the point to be able to distinguish between what you said. Could it be necrosis? Could it be an inflammation, pseudoprogression? Or do we have a case with really a true progression that might be amenable for additional treatments, such as surgery or stereotactic radiosurgery, right? So our agent is called Red 101. It does have the potential to address a really, as you already saw, I believe, from Dr. Rajendran's presentation, a huge unmet medical need. In the US alone, there are 300,000 new subjects diagnosed with brain metastasis every year. So it's very far from being a rare condition. And it is important that we, as treating physicians, are able to identify and treat such recurrent brain metastases early enough. And the standard of care for such patients is MRI, which is not sufficient, as I believe you saw very, very nicely presented from Dr. Rajendran, in especially the case of patients who have undergone surgery or especially stereotactic radiosurgery. So we have published positive phase 2 data that I will share with you that demonstrate that we have a high tracer uptake in all patients that were underwent the study, and regardless of the origin of the primary tumor. And further, that there was, at least in the sample size or in the study, a correlation between a high SUV, which is the uptake essentially of the tracer that you can distinguish in the PET, and a short survival, which could be, if it's confirmed in the larger study, of course, be a non-invasive way to predict survival. We at RAD have currently a phase 2 study ongoing that's really recruiting very, very well. Dr. Rajendran is part of this study, and it's going really well, and we will be able to finish that study hopefully very soon. So the agent that we have, RAD101, is a small molecule, which with the linker we have attached to the radioactive isotope, in this case F18, which of course we use for the diagnostic purpose here. The target of this whole construct, RAD101, is fatty acid synthase, which is a very important enzyme for brain cancer cells to survive in the brain microenvironment. So by targeting and disrupting fatty acid synthase activity, we are able to impair the growth and, of course, also making it visible to the eye through the diagnostic imaging as a PET agent. This is a first-in-class phase 2 imaging study. As I said, there's a very high unmet medical need for those patients in this not very rare condition, actually. And we don't currently have any other competitors in the field. So what exactly is behind fatty acid synthase targeting? Very briefly here, a couple slides on the mechanism of action. So what happens is basically that patients need to be able to upregulate their own lipid synthesis, because in the brain itself, the microenvironment is actually not nutrient rich in terms of the lipids that those cells need. So there are certain cells that are pre-activated to have this lipogenic program switched on. When those patients metastasize to the brain through the bloodstream and then the blood-brain barrier, they are able to develop brain metastases through their own upregulation of the synthesis of lipids that they need to grow in the nutrient-poor brain microenvironment. This is not just a metabolic adaptation for the cancer cells to survive, but it can make cancer cells also more aggressive and then also resistant to various treatments. Okay, so in addition to what I already explained in terms of the lipid synthesis, fatty acid synthase has also a very relevant pro-oncogenic function itself, in the sense that it avoids it leads to the cancer cells being able to avoid immune destructions. It activates invasion of metastases, invasion and metastases. It induces angiogenesis, it induces resistance to cell death, deregulates cellular energetics, and sustains the proliferative signal that many of these cancer cells have activated de novo. So it's involved in sustained proliferation, dysregulation, resistance to cell death, activation of invasion and metastasis, and prevention of immune destruction. So it's not just that it leads to the cancer cells being able to produce their own lipids, it is itself also contributing to sustained tumor growth. So being able to target this, of course, makes a whole lot of sense, right? So this is one slide where I can just, hopefully summarize for you the preclinical data. We were, in our collaboration with Imperial College in London, able to generate an enzyme or a target against this enzyme, which is metabolically very stable. You can see that here. A single peak, as you can see here, in the various organs, including the plasma, means that there are no metabolites, so it doesn't change when it's being injected into a patient. There's a rapid accumulation of pivalate. So pivalate is another name for Red 101 or 18-fluoride FPIA, so pivalate or Red 101. When we implanted it in vivo into mice using human and murine adenocarcinoma cells, we saw a rapid and very extensive tumor localization. Being a small molecule, of course, it is taken up and cleared through the kidneys. And it is superior in many of the brain cancer models that were studied, superior to FDG-PET. You know that FDG-PET is another very popular method for PET detection of metabolic activity of cancer cells. However, it is not appropriate for brain metastases because not so much of less detection, but because the brain itself has a high baseline of glucose metabolism. So you cannot detect the difference. Our agent, Red 101, has a very superior tumor to brain ratio compared to FDG. They were able to very, very well localize brain metastases in these preclinical models. As we discussed already a few times, brain metastases are actually, or unfortunately, a common occurrence. You can see here on the left side that 10 to 20% of all lung cancer patients, up to 50% of triple negative breast, up to 50% of HER2 positive breast, and 15 to 60% of all melanoma patients can develop brain metastases. And among those who have developed metastases to the brain, accordingly, the majority is lung cancer, breast cancer, and melanoma. So we discussed already how those patients are being treated. This is one example on the right hand from a breast cancer study where you can see that in comparison with whole brain radiotherapy, stereotactic radiotherapy does lead to an improvement in survival. Now, these are old data. Newer publications are able to show that even for patients with a larger number of metastases, this is an active treatment, so the survival has improved somewhat, but it's still, of course, a very difficult medical condition. But the earlier this is detected, and especially the earlier the relapse is detected, the better are the treatment modalities. So this is, in a nutshell, the therapeutic approach. Patients are being screened. For that, the MRI is good. Then they're being diagnosed here in panel number B. They do receive, as we already saw very nicely from Dr. Rajendran, their stereotactic radiosurgery or surgery. And then it is important at that point, the patients, of course, continue to get additional, after the procedure, additional imaging. And the MRI is, as I said, not very good in detecting that. So monitoring the treatment effect and being able to early detect metastases versus necrosis or pseudoprogression is obviously very, very important. The compound has been studied in phase 1 and phase 2 through the Imperial College in London. These were studies conducted in the United Kingdom. We are currently running our own phase 2b study in the US, and the phase 3 study would be a truly global study going forward. So, short summary of the existing phase 2 data. The objectives of this trial were to identify the selective uptake in brain metastases, to understand the impact of stereotactic radiosurgery after 4 to 8 weeks in 2 cohorts of patients who were both treatment naive and SRS pretreated. In summary, the study results showed that there was a very high uptake independent of primary tumor. that there was high uptake in all patients compared to contralateral brain matter, and patients with an SUV uptake and SUV max of more than 2 showed a particularly short overall survival as opposed to patients who had a lower SUV. 3 slides on this study very briefly. Again, the first question was, is the agent able to identify all patients, all brain metastases, irrespective of, the type of tumor? So, and you can see the brief response to that, whether patients were treatment naive or SRS pretreated, and whether they had lung, breast, melanoma, or colorectal. Basically, you can see all the values here are similar. So the SUV max and also the tumor to background ratio do not show a difference between lung, breast, melanoma, and colorectal cancer metastases, which are, as I already said, the most frequent ones. The other question is, can we differentiate with this agent between patients who had received prior treatment and those who were treatment naive? And the answer is yes. I believe you can see this very nicely on the upper 2 images, being a patient who is treatment naive. So this patient had a relatively similar expression in terms of both the MRI and the PET. The PET is green, the MRI is red. So they do show pretty similar activities here. But when you then looked at a patient that was pretreated, you see a substantial difference here. So the PET here and here shows an area that is larger than it was identified with the MRI. In other words, this patient, if this patient would only be treated on the MRI identifiable lesion, they would probably receive treatment that's not enough to cover the entire tumor area. And then the last finding that I already mentioned, which is very interesting and very important, obviously, is the potential of a non-invasive prediction of survival. So the upper panel of 3 images shows a patient with a high SUV over 2, 3.3. And as an example, on the lower part of the slide, these are lesions from another patient who had a low uptake. And you can see here that the patient with the high uptake had a progression-free survival of only 1 month, an overall survival of only 4 months, as opposed to the other patient who had an overall survival of 34 months. So the study was conducted, as I said, by Imperial College in London. They did the statistics. Of course, this is still a small study, and we will have to see if we can confirm those results in a bigger study. But I believe the results are very striking. As you can see, it's a very, very clearly statistically significant effect. So where are we now in terms of our own study? As I said, the study is running. Patients are eligible if they have brain metastases from all these tumors shown here and suspected relapse. They then receive a whole brain PET with a low dose of our agents, and the endpoints are concordance between PET and the MRI, and the patient also receives then a 6 months longitudinal follow-up. We're enrolling the study. We will have early interim data end of the year or second half of this year, of course, and then the last patient dose at the end of this year, beginning of next year, and we'll be able to have a phase 2 readout then in the early half of 2026. So the design that we have, as already mentioned, subject with advanced solid tumors with known history of brain metastases and suspected relapse following stereotactic radiosurgery. So to conclude, and this is my last slide, the early identification and treatment of recurrent brain metastases is an area of really high unmet need, with standard of care imaging such as MRI being insufficient. RAD 101, we think, has the potential to address this medical need. The existing and published preclinical and clinical data clearly demonstrate that the technology works. We do have clinical proof of concept in the phase 2A. We have those positive phase 2 data published, and they demonstrate a high uptake in all subjects, irrespective of the primary tumor. We can show better differentiation of pretreated lesions versus the MRI. We have a potential correlation between high SUV and short survival, which could indicate the potential to have a non-invasive OS prediction. Our study is well underway, recruiting subjects very well, with the phase 2b readout being the first half of next year. We are in the planning stages of the phase 3 to address this existing gap. And as already said, because there is no other competitor, a potential approval would be, for us, of course, a unique position of leadership in the field. So that's all I had. And I'm very happy to hand over to Ricardo.
Thank you, Dr. Rajendran. Thank you, Dimitris. Let me share my slide. I have a few minutes of a presentation, and then I'm happy to, of course, go to the Q&A in a moment. From a Radiopharm Theranostics point of view, RAD101, the products that we are discussing today, is our most advanced technology in phase 2b. I saw a question in the chat asking what is the difference between a phase 2a and phase 2b. Well, in our specific case, the phase 2a was in 22 patients, but only half of them were post-SRS. And the trial was performed in a single academic center. So 11 patients in a single center. Our phase 2b is 30 patients, so 3 times bigger, in 5 different centers under the regulation of FDA. So it's a very different validation, of course, before you can go to registrational trial. Today the focus is 101, as I said, but I just want to take the opportunity to thank you, the team and everybody in Radiopharm, for the great progress in the last months. We now have 5 clinical trials ongoing, and we will have the 6th clinical trial ongoing by the end of the year. So the full pipeline will be in the clinics. That, of course, for a company that is only 4 years old, is a major achievement. But let's stay on RAD101. This is a slide that Dimitris already showed. I just want to focus your attention on 2 elements. There are ongoing imaging trials in glioma, high-grade glioma, but there are no advanced trials in brain metastases. We are by far the first and the only ongoing late-stage development to image brain mets. And this is a unique and a very positive competitive situation, considering that there are so many patients affected by the disease. It's around 300,000 new patients every year, only in US, as Dimitris was stating before. But I would like to go a little bit deeper in terms of expectation and timelines. So we started this trial in the first half of 2025. That's when we dosed the first patient. We are well on track. It will always take a little bit of time to set up the center and to start, but the recruitment that we saw, in particular during the month of September, that is not finished yet, is really great. So we believe that we can be at least at 20 patients, if not the entire 30 patients, by the end of the year or the end of January. Then we need some time to put together the data and the readout. But what we have decided as a team, that considering the positive data of the phase 2A and the early positive data that we have seen in the phase 2B, we have decided to start the preparation of the phase 3. We think that these products has very good probability of success that can be proven in a registrational trial. We are preparing at risk. That doesn't mean that we will go full speed in a month, but we will prepare to be ready to go full speed as soon as we have visibility in a little bit higher number of patients. But what we have seen is very, very important and highly, highly promising. So we think that we can start the phase 3 next year at the end of 2026. You should assume a trial of about 150 to 100 patients. So between 12, 18 months recruitment. So this will give us a unique opportunity for a NDA submission at the end of 2028. So that means that the product is ready to be approved by FDA from a commercial launch. Why we decided to accelerate the development and the preparation of the phase 3? Well, we recently saw great success in the market of two imaging agents in a completely different area, that is prostate cancer. Illuccix from Telix, Pylarify from Lantheus are now called blockbusters, so products with an yearly sales that is above $1 billion per year. So we asked an independent company to do an assessment to tell us where Pivalate stand if we are able to successfully image the brain metastasis in the patient that we discussed during this webinar. And we were very pleased when we saw that Pivalate, or RAD101, has the potential to be the third largest imaging agent on the market. The assessment, again, was not our forecast, was an independent assessment that was telling us that the potential is above $500 million per year, 750 million Australian dollar per year, and this is only in US. So this is not including Europe, Australia, China, Japan. That's US only. So this number, of course, very important and are giving us the confidence that there is a unique opportunity to take. I always like to say that the sales are the results, are the outcome, but what is more important is our ability to serve the patient. There is a huge unmet medical need here, has been described by the speaker before, and we are very highly motivated to give our contribution in the space, and as a result, to capture, of course, the commercial opportunity. And with this, thank you from my side and all of you that are attending, but we don't want to miss the opportunity to answer to all your questions. So I give it back the ownership to Dimitris to select the right people to answer your question. Thank you very much.
Thank you, Riccardo. So I'm going through the list of questions here. A few are for Dr. Rajendran, a few that we can address from our end as read. So again, Ramji, I believe people are asking, how many patients do you really see with brain metastases in a busy clinic every year? Some people, I believe, still think that this is not a very frequent condition. So if you could maybe repeat, some of the things you said around the prevalence, the incidence, or how often this happens.
We treat with gamma knife radiosurgery, and I'm in the gamma knife center once a week. We typically treat about 3 patients to 6 patients every week. And I would say altogether, we have approximately 150 patients that we treat per year, specifically with gamma knife radiosurgery. That's very different than patients that receive whole brain radiation and other treatments. Sometimes we observe patients, especially if they're amenable for immunotherapy, such as melanoma patients. But this is a frequent issue and a frequent problem with the most prevalent of cancers, lung cancer, breast cancer. And so I think that it would be wrong to say that this is not a frequent occurrence and something that we encounter very regularly in the clinic. I'm not in an academic institution. I'm at a community health system, and I feel like I represent the majority of radiation oncologists in practice. And so I may see more because of the fact that I do gamma knife radiosurgery, and I'm sort of top of mind for the neurosurgeons that I work with, but it is very common.
Thank you. Yeah, I mean, I agree. As I hopefully was able to show, when you have tumors where half the patient has, let's say, triple negative breast cancer, or melanoma, or more than half metastasize to the brain, I don't think you can call that a rare condition. So it's really not.
And indeed, I wish it wasn't as common, but
Yeah.
it's also it leads to very poor quality of life. I mean, nobody wants to die a neurologic death.
Yeah. Thank you. One question that we had around the phase 2 versus phase 2b study. So the difference between the phase 2a, that this was an investigator-initiated academic study conducted at and by Imperial College in London. They treated patients who had treatment-naive patients, but also patients who were pre-treated, as opposed to our study that is obviously, a study conducted by us, by a biotech company, and we only exclusively include patients with prior stereotactic radiosurgery. Another question, maybe again for you, Ramji. So what's the appropriate treatment if a substance like Red 101 identifies early brain mets? Does it vary by tumor origin, or are they basically the same, or how do you differentiate what treatment those
It's
patients
typically
get?
surgical resection, and the earlier you're able to resect, you'd imagine if you can resect a smaller tumor because you see it sooner and catch it sooner, there's less morbidity and mortality associated with resection of a smaller tumor. Furthermore, there are in development treatments that penetrate the blood-brain barrier and systemic treatments that are options that are available. And I think those are also going to be potentially alternatives for such patients.
Great, thank you. Another question maybe that you and I can jointly answer is what gives us the confidence that this technology could work. So maybe I can start and then you chime in. So I was hopefully able to show you that we have an agent that is um, very specific, targeting an enzyme that is key to the survival of brain metastasis. And we have demonstrated in preclinical experiments that we can do this very successfully with an agent that, is very, very specific, targeting those cancer cells that express this enzyme. And we have a very strong proof of concept in the clinic also from the Imperial College of London data. But maybe Ramji, also from your end, you're part of the study, you enrolled a few patients. Tell us a little bit about your experience and your perspective.
I mean, recurrent tumors light up. It's that simple. I don't know if I'm giving away any secret, but I find that it's um, recurrent tumors are shown to be active on PET with this agent, and the study is not yet meant to change treatment, but it sure does give me pause, and I want to act sooner for those patients because I think it's the right thing to do clinically. But I think it's effective, and I think this is why we do the trial. This is why we do the study, and this is we're just at the cusp of a theranostics revolution. Okay, and this is going to be an amazing opportunity to kind of be one of the early movers and really be able to capture a large portion of clinical practice and ultimately affect the lives of multiple patients and provide a way in which we can have them live with a better quality of life for whatever time they have left.
Yeah. And what about survival benefit in patients who are detected early enough?
So I think survival benefit is always harder to prove when you have so many different tumor types, when you have so many different treatment options. I think that we have to take it on a case by case basis, and ultimately, you would want an agent that could change practice, and even radiation to the brain is still considered palliative because you have a metastatic incurable patient. It's just that the systemic treatments are so much better now that this ends up being their rate limiting and life limiting issue. So I think that it is hard to prove overall survival in this setting, but ultimately it does dramatically affect clinical practice.
Thank you. Yeah, and as we saw from the phase 2 now, of course, there seems to be a very strong correlation between a high SUV and survival. So obviously, this is going to be something we will investigate in the phase 3. The phase 2 data are very promising. I mean, it makes sense, right? I mean, if you have a tumor with a very high metabolic activity, you have a high SUV, and it's, would be logical to assume that in a patient with a very aggressive tumor, very high expression levels of fatty acid synthase, that patient would have a shorter survival. I have also two questions for Ricardo. Ricardo, I believe we answered the question around the start of the phase 3, when we will have the phase 2 complete and the data. But two questions also for you here is about the competition to Pivalate, and the other one, whether we would consider, partnering, out licensing at the end of the phase 2.
Yeah, thank you, Dimitris. And if you don't mind, I'd like to start with another question, and I will immediately answer to those that I see on the chat, because the question, I hope I don't disclose anything unfair. I saw a question from Dr. Pisaneschi. Dr. Pisaneschi was at Imperial College of London, and she was co-inventing RAD 101 or Pivalate. So thank you, Dr. Pisaneschi, for being with us. Your question about other indication. Well, we know the data that probably you contributed to generate in glioma and in solid tumor for Pivalate due to the, of course, presence of fatty acid synthetase, not only in brain mets. For the time being, we like to stay focused on the brain. So brain mets is the primary important area of focus, but we are aware of some preliminary data, in particular in glioma, high-grade glioma, so we cannot exclude that this is an area where we want to go after brain mets. Back to the question of Dimitris, will we partner Pivalate after phase 2? Well, doing a phase 3 trial is a very important investment. As I mentioned before, we have the intention to prepare and to start this trial, but we are definitely very open to consider the support that we can have from larger organizations if there is a strong interest in conducting a global multi-center phase 3 trial that can be faster than what we can do alone, because at the end of the day, we want these products to be to the market as soon as possible for the patient benefit. So we will definitely be open to partnership. Sorry, Dimitris, what was the other question apart from for the partnership? Was about, I forgot what you asked me.
The partnership and out licensing potentially, and the market size we covered.
Yeah, we covered.
One other question is, we covered it, but maybe clarify again what the competition is for Pivalate at this point.
Yeah. So look, there has been a trial that tested a different agent in phase 3 in the last couple of years. Unfortunately, that trial was not successful. It was a different molecule with a different mechanism of action. So due to my knowledge or due to the public information, I'm not aware of any agent that is currently in clinical development as an imaging from brain metastasis. So from this point of view, there is no agent that is even in phase 1, and we are in phase 2B, and potentially less than a year from registrational trial. That means that we have a number of years of advantage compared to any other molecule in competition. That's why we want to maximize this opportunity. That's why we are open even to partnership, as I mentioned before, because we would like to go full speed, and we just want Dr. Rajendran to give us even more beautiful images and data on his patient that will further increase the confidence that we are in the right trajectory.
Thank you, Ricardo. So when another question is at the next data update, how many patient data will we be able to present?
Yeah, well,
You covered
Dimitris,
that, yeah.
I think it depends on what we mean data update. If you follow how the trial has been designed, there are the data that you can have right away, like 24 hours after the patient is dosed. And then there is the 6 months follow-up. You want to check, if comparing with MRI or standard of care, pivalate is keep saying and keep giving the correct answer. So on the short term, we are very fast. As I said, the trial is enrolling very well. But if we want to give the patient data that include the 6 months follow-up, even if we are highly advanced in the recruitment, we need some more months to get there. What I'm saying in this complicated answer is that we likely have 3 to 5 patient data very soon, and probably we will have 10, 15 patient data in few months from now before the final readout. So I expect to have a couple of interim before the full and final readout.
Thank you, Ricardo. So obviously, that was another question, how's the enrollment going? I believe we answered that. We have very enthusiastically enrolling sites and investigators, but we also need to have the 6 months follow-up for every patient to understand really, whether they indeed have a progression or if they have a biopsy, what the result of the biopsy is. So to keep that in mind, that's part of the study as well, and that's what makes it actually 6 months longer, right? Dr. Rajendran, another question is really interesting, more practical, whether Red 101 or pivalate can be detected or whether it can be used with regular machines, if you need any specialized equipment, anything that you don't have in the clinic.
We don't have anything special. We're a community hospital. We have a regular PET scan that uses that's used all the time for FDG PET, for PSMA PET, and so there's nothing unique about what we can offer. There's no special technology. If you have a PET scanner, this works, and it's pretty interesting. I have my radiologist actually called me when we had the first few of these patients, just because it was exciting to see something different, and it was really neat to hear directly from a person that wasn't necessarily involved in the trial to say that this is a really cool thing. So it's exciting.
Thank you. Another question that we had is, what is the smallest tumor size that you can detect? Well, that's an interesting question because I believe, it shows some of the ideas behind, or answering this. We can illustrate some of the benefits of the technology. So the MRI is an anatomical imaging where you look at the anatomical size of the lesions, less than 1 centimeter, more than 1 centimeter, and so on. PET imaging is functional. So you can have a lesion that appears bigger in the PET scan, even if the anatomical size of the lesion appears small, because the PET does not show anatomical, but functional imaging. So that's really the key difference. We differentiate between very active and maybe less active lesions. And again, that's also the point of what I said, the correlation that we saw, or that actually the colleagues at ICL saw with the survival between the SUV and the survival. Another question maybe that we got is whether we could get an early approval after the phase 2B. That is unlikely because for diagnostic agents, the standard, there is no accelerated approval as you have for therapeutic agents, where with a very strong response rate, you could maybe go down the path of an accelerated approval. So the agency, the FDA, that is still using sensitivity, specificity, and accuracy as the primary endpoints, especially for imaging trials. However, the size of such an imaging trial is typically much smaller than that of a therapeutic study. So we believe that the study can be as small as 150 or maybe 200 patients, which is actually the size of a large randomized phase 2b with the therapeutic. So unlikely based on the phase 2b, but the phase 2b will be very informative, of course, for us planning the phase 3, and the phase 3 is not going to be a very large study.
I'd rather have a very strong body of data and body of work and really trust that we have a good agent than try to rush it.
Yeah. Good point. Another question, let me go through this. Whether we have to show superior outcomes or as good as standard of care. Well, essentially, yes, we need to be better than standard of care, but the way that the trial will be designed is that we have a certain cutoff values agreed upon with the agencies, that we can show the sensitivity, we can show the specificity. Those analyses, for example, include patients, identify the number of patients who are false positive or false negative, and the direct comparison between the MRI and the PET. Let me just double check.
Maybe Dimitris, the question on the
Maybe
therapeutic.
Ricardo.
Yeah.
Well, maybe one more for you, Ricardo. Many investors focus on the therapeutic radiopharmaceuticals. Why should investors be excited about the diagnostic technology?
Look, this is absolutely true. Many times when we spoke with investors, their first focus is on the therapeutic agent. But at the same time, we saw equal number of investors that has been aware of how transformational the imaging agent in prostate cancer has been for companies like Lantheus and Telix. So this has really changed the valuation of the new imaging agent. Until that day, the largest imaging agent was probably NetSpot for neuroendocrine tumors in around $100 million, and now we are talking products in the $2 billion range. So we believe that in the current environment, if you can offer very specific imaging agent that can be combined with a therapeutic option like it is SRS, and this can help patients to be diagnosed and treated earlier. The value is recognized in the products, and this translates in the future potential. So as a company, we believe that the imaging agent has the opportunity to be faster to market, less expensive to develop, and still have a very important potential. At the same time, we are also working on therapeutic agent because we definitely see the value of radiopharmaceutical therapies as a new approach to targeted therapy. And maybe this is a good continuation to the question that I see below saying, have you considered making Pivalate a therapeutic agent in addition to the current imaging? And the answer is yes. We tried once about 2 years ago and we failed. Pivalate is a small molecule, and when we attach an isotope, the isotope was too potent and the molecule was not stable. But we learned from it, and now we are making a second attempt. We modified the molecule in a way that is not changing its ability to interact with the fatty acid synthetase, but can support a stronger therapeutic isotope. So we are working on preclinical, on a project to do a pivalate therapeutic. We don't know if the right indication will be brain mets or glioma, but as we have such a molecule with such a strong ability in terms of having tumor uptake, why not to think about a therapeutic option? So it's not something that we can present data in 6 months. It's a longer term project, but we definitely are working on it.
I mean, forget about brain metastasis for a second. There are things that where we can't help patients. There are things like leptomeningeal disease, where we're left to really just patients go to hospice like they did for brain metastases. So, and a therapeutic agent would be a huge, huge benefit. So,
thank you.
Very good. I think, maybe one additional question at the end. Dr. Rajendran, just out of interest from the audience, if the immune system is any different within the blood-brain barrier as opposed to outside in terms of, how the immune system tackles potentially brain metastases.
So the brain is a sanctuary site, as I mentioned. Therefore, a lot of the molecules that work great in the body don't work as well in the brain, including larger molecules such as antibodies. So I think it's really imperative that both diagnostic and therapeutic opportunities are available, and I think that it's just different. The being a sanctuary site, there are differences in the brain than the rest of the body, and we see immune dysfunction in the brain, right, with disorders like multiple sclerosis, which we still have a lot to understand. But the simple answer is yes. And just as much as I respect that what we do is pretty cool, there's still a lot we don't know, and we have a lot to learn. So.
Thank you. Thank you so much, Dr. Rajendran. I think we have answered all the questions. Of course, if there are any additional questions that come up from the audience, we are obviously all available by email. Do not hesitate to contact us. If something comes to mind, please let us know. But at this point, I'm happy to say we are almost 15 minutes over, which I believe just is a testament to the great interest. Thank you, Dr. Rajendran, for this absolutely outstanding presentation, which I believe was able to showcase not just your personal interest, but also why this is so tremendously important for patients and for their benefit, for their survival, for their therapeutic options, and us collectively, you yourself personally, the other study investigators, me as a CMO, and the entire team, CEO, Ricardo, the entire team at Radiopharm. We are really excited about this compound. We are excited to finish the phase 2 and hopefully bring this to a point where it can be made available for patients. So thank you, everybody. Thank you for your help with the webinar here, Ramji, and we'll stay in touch.
My pleasure. Thanks for having me.
Thank you. And again, to the audience, if you guys have a question that we didn't answer, or you have a new question, then please let us know in writing by email. Thank you so much, and everybody have a great day and a good evening. Thank you.